Okay, let's dive right into this explainer. When it comes to pediatric caregiving, it really is the ultimate detective work. Finding those super subtle physical clues can quite literally save a child's mobility and health for the rest of their life. Because infants obviously can't just tell us where it hurts or articulate their symptoms, we have to rely entirely on what we can objectively observe. So, today, let's jump straight into the source material and investigate pediatric skeletal and internal defects. Here is our quick roadmap for the explainer. First, assessing pediatric body systems. Second, what is hip dysplasia? Third, spotting the signs of DDH. Fourth, treating DDH by age. And finally, other common skeletal defects. Let's get to it. Section 1. Assessing pediatric body systems. So, because babies can't articulate their pain, investigating internal systems like the kidneys requires us to look way past the physical surface. We literally can't see genitourinary dysfunction with the naked eye, right? So relying heavily on lab tests is absolutely crucial here. The single most important test is often just the routine urinalysis, which gives us immediate, massive clues. We also look at blood tests like blood urea nitrogen, or BUN, to measure kidney function. It's just a great reminder that sometimes the absolute best clues we have come straight from a lab. Now, the data shows that simple preventative measures solve a ton of internal mysteries before they even start, specifically when we're talking about preventing urinary tract infections in kids. It really just comes down to essential hygiene. You know the drill: wiping from front to back, avoiding tight clothing or overly tight diapers, wearing breathable cotton panties instead of nylon, and making sure kids don't hold their urine. Encouraging frequent voiding is such a simple measure, but it protects the entire system. Moving on to Section 2, what is hip dysplasia? Okay, let's shift our magnifying glass and focus heavily on one of the most critical orthopedic investigations out there: developmental dysplasia of the hip, or DDH. The crucial point to understand here is that DDH isn't just one single condition. It actually describes a whole spectrum of disorders related to the abnormal development of the hip. It affects about 1 to 2 infants per 1,000 live births in the US. It definitely occurs more frequently in girls. And a major kind of surprising clue is birth position. Up to 40% of infants with DDH are actually born in a breech position. Plus, genetics play a huge role. If a parent or sibling had it, the risk absolutely skyrockets. Think of it like a puzzle piece slipping out of place. In a perfectly normal hip, the joint is beautifully socketed. But as this condition progresses, you can actually visualize the head of the femur progressively losing contact with that socket. The source material breaks the spectrum down into 3 distinct degrees of severity. First up is acetabular dysplasia, which is also called preluxation. This is the mildest form. The femoral head is still completely in the socket, but there's a delay in development, meaning the roof of the socket is just too shallow and oblique. Second is subluxation, and this actually makes up the largest percentage of DDH cases. It's an incomplete dislocation. The head of the femur is still technically touching the acetabulum, but the capsule is stretched out, causing it to be partially displaced. Finally, we have full dislocation. This is exactly what it sounds like. The femoral head completely loses contact with the socket and is displaced backward and upward. At this point, the ligament becomes severely elongated and taut. Section 3. Spotting the signs of DDH. Here is a wild fact. X-rays actually aren't reliable at all in infants under 6 months because their skeletal structure is still mostly just soft cartilage. Because of that, physical clues are absolutely everything. You have to look for asymmetric thigh and gluteal folds when the infant is lying on their stomach. One side just won't match the other. Then there's the Gileadzi sign. If you bend the infant's knees while they're lying flat, one knee sits noticeably lower than the other. Why? Because the femur on the dislocated side literally appears shorter. You'll also see restricted abduction, meaning that affected hip just can't open outward nearly as far as the healthy one. Now, the clinical clues actually change as the child grows, which is super interesting. For infants, caregivers use very specific physical assessments, the Ortolani M. Barlow maneuvers. The Barlow test actively dislocates an unstable hip by bringing the thigh in and applying backward pressure. Then the Ortolani test reduces it. The thighs are opened outward, and if it's positive, you'll feel a distinct tactile clunk as the femoral head slips right back into the socket. But in older children who are already walking, the presentation changes entirely. You might see telescoping, where the leg sort of pushes up and down like a piston. You might observe a waddling gait, or you'll see a positive Trendelenburg sign, which is when they stand on the bad leg and their pelvis physically tilts downward on the normal side instead of staying level. Okay, the source material highlights a massive alert right here, and we need to talk about it. Manipulating a newborn's hip with the ortolani or Barlow maneuvers is incredibly serious business. If too much force is applied, it can actually cause permanent damage. The literature aggressively stresses that these tests must only be performed by a seasoned, experienced clinician to avoid accidentally harming the infant's super delicate joints. Section 4. Treating DDH by age. Once we've cracked the case and spotted the dysplasia, early intervention is literally everything for a favorable outcome. The longer the delay, the more severe that deformity becomes. From newborn to 6 months, treatment relies on dynamic splinting, usually a harness. But if the condition isn't caught until 6 to 24 months of age, the child often already has muscle contractures. That requires traction to gently stretch the hip out, followed by a closed surgical reduction and months in a spica cast. For older children, it becomes inherently much more difficult because their body has already adapted to the deformity. They usually require major operative reduction. We're talking lengthening contracted muscles and doing pelvic osteotomies to physically construct a brand new hip roof. Let's look back at that earliest intervention. The Pavlik harness is a really fantastic device used for newborns up to 6 months. It's cool because it doesn't rigidly lock the baby in place. Instead, it uses time, motion, and gravity to gently guide the hip into a safe, deeply flexed, and abducted position. It centers the femur perfectly right into the socket. The catch? It usually has to be worn continuously, 22 to 24 hours a day for 6 to 12 weeks. The absolute key takeaway for caregivers here is learning how to maintain this harness and adapt daily care routines without ever adjusting the straps themselves. And here is a surprising fact from the research that totally busts an old myth. Throw out the old wives' tale of double or triple diapering to fix a bad hip. Seriously. In the past, people thought the extra bulk of multiple diapers would keep the hips spread far enough apart to heal. But today, the medical consensus is crystal clear. There is absolutely zero evidence to support its efficacy. The recommendation is firmly 100% against it. Section 5. Other common skeletal defects. To round out our orthopedic investigation, we have to look at 2 other conditions. The first is metatarsus adductus, which is actually the single most common congenital foot deformity. It's a result of abnormal positioning in the womb, and we see it a lot in firstborns. The toes and forefoot point inward, basically making a kidney shape. It's categorized by flexibility. Type 1 is highly flexible and corrects easily with just gentle manipulation. Type 2 is only partially flexible. But Type 3 is totally rigid. It won't stretch to neutral at all, and these infants require serial casting to fix the foot. But here is the most incredible takeaway from the data. If a baby has this foot deformity, caregivers absolutely must thoroughly examine their hips, because foot deformities are closely associated with an increased risk of hip dysplasia. They go hand in hand. Finally, we have slipped capital femoral epiphysis, or SCFE. Imagine this, a pre-adolescent, often obese, who suddenly develops a severe limp or starts complaining of vague groin, thigh, or knee pain. What's actually happening is terrifying. The upper part of the femur bone is literally slipping right off the growth plate. If you even suspect this, it requires an absolute immediate halt to all walking. The child must be completely non-weight-bearing. They need surgery within 24 hours to pin the bone back into place. If they don't get it, they risk avascular necrosis, which is the total loss of blood supply and the actual death of the bone. It's a true emergency. And that brings us to the end of this explainer. From checking for asymmetric skin folds on a tiny newborn, to listening for that subtle clunk during a hip exam, to stopping a limping teenager from putting weight on a slipping joint, the evidence is just incredibly clear. Early observation is the absolute difference between a simple, early correction and lifelong, painful damage. The subtle clues hold all the answers. So the question is, are you looking closely enough?